Management of aortic dissection. A history of is important. In 1761, Morgagni described the dissecting aneurysm. 1804, Scarpa dissection related to corrosion and rupture of the proper course of aorta, hematoma resulting from the blood dissecting through the arterial wall. 1826, Laennec introduced the term dissecting aneurysm. 1855, first antemortem diagnosis of dissection. 1843 to 1863, Thomas Peacock cadaveric experiment, ruptured intima lacerable and blood penetrating the media and distal re-entry, imperfect nature, cure. 1864, von Recklinghausen attributed dissection to molecular changes in elastic tissue. In 1910, Babies Morinescu told that the aortic dissection could occur secondary to hemorrhage in vasa vasorum, dissecting meniscarditis. In 1910, Moriani showed the microscopic changes in elastic tissues and connective tissue media. In 1928, Eldheim showed cystic medial necrosis as underlying cause. In 1934, Shinan showed the dissecting aneurysm degeneration of media frequent and neither atheroma nor leaves were important. In 1943, Oppenheimer and Taussig first described the ascending aortic aneurysm in Marfan syndrome. Hatter and Glover first described the ascending aortic dissection in Marfan syndrome. In 1955, McCusick documented the aortic dissection in the common cause of death in Marfan syndrome. In 1958, Hurst reviewed 505 cases of atherosclerosis and related factor. In 1973, Gore and Hurst showed rupture of vasa vasorum initiating event. Pathogenesis. Intimal tear is a primary event, propagation of the dissecting hematoma within the media. Intramural hemorrhage due to rupture of vasa vasorum is in a definitive media. Intimal tear is secondary event and propagation of cleavage plane by pulsatile flow of blood. Risk factors: the role of abnormal aortic media, cystic medial necrosis not always present in dissecting aorta, also present in patient without dissection. Aortic dissection associated with connective tissue disease, the Marfan syndrome, Ehlers-Danlos syndrome, aortic dilatation, thoracic or abdominal, often familial. Aortic dissection associated with bicuspid aortic valve, aortic coarctation, and Turner syndrome. Risk factors: Marfan syndrome present in 5 to 10% of the ascending aortic dissection, 0.02% of adults, aortic dilatation, bicuspid aortic valve coarctation, Ehlers-Danlos syndrome, Noonan syndrome, family history of Marfan syndrome, aortic dissection, and aortic disease. Hypertension present in 70 to 90% of dissection, or 20 to 40% of adults. Features including very long arms, fingers and toes, pigeon breast or severe pectus carinatum, moderate to severe scoliosis, dislocated lenses, family history of Marfan syndrome. Cardiovascular system major criteria is dilatation of ascending aorta and aortic dissection. Minor criteria is mitral valve prolapse, dilatation of the male pulmonary artery, premature mitral annular calcification, less than 40 years, descending thoracic or abdominal aortic aneurysm, and cardiovascular involvement, one minor criteria. Ocular system, ectopia lentis. Skeletal survey may show presence of at least 4 of the following: pectus carinatum, pectus excavatum, reduced upper to lower segment ratio of the arm span, waist and thumb signs, scoliosis, 20% of the spondylolisthesis, reduced extension of elbows less than 170, medial displacement of the medial malleolus causing pes planus, and portio acetiobulae of any degree. Prolonging the life needs correct diagnosis, medical management, and surgical repair. Clinical evaluation, there is a complete physical examination. Physical examination should be done, including a careful musculoskeletal and skin examination, detailed medical and family history, ECG and echocardiogram looking for the cardiovascular involvement, eye examination by ophthalmologist who dilates the pupil and uses slit lamp to assess the lens dislocation. This series of steps is important not only to determine the diagnosis but also detecting the problems that require immediate attention of long-term management. Management includes weak connective tissue cannot withstand normal tension on aorta since the tension is proportional to P into R. Avoid strenuous exercises that increase blood pressure. Use medicine to lower blood pressure and dP upon dt. Beta blockers, verapamil, non-calcium beta blockers or ACE inhibitors that lowers BP. Replace the aortic root valve when the aortic diameter is more than 6 centimeters without AR or more than 5 centimeters with 3 plus to 4 AR. Etiologic mechanism, the intimal tear with secondary extension into the media, hemorrhage into the media precipitating the secondary intimal tear, intramural hematoma and penetrating atherosclerosis ulcers can lead to dissection. Classifications include DeBakey and Stanford. DeBakey type 1 is ascending aorta extending beyond the arch, type 2 ascending aorta only, type 3 descending aorta, type 3b descending aorta extending below the diaphragm. Stanford classification as A ascending aorta, B is descending aorta. Ascending dissection, 65 to 75% of dissection intra-tear within a few centimeters of the aortic valve and 50% extend to iliac bifurcation. Descending dissections, 25 to 35% of dissection, false channels begin distal to the left subclavian, variable extension. Complications. Rupture through the outer wall of the false channel, typically directly across from the intra-tear, pericardial tamponade, mediastinal or pleural rupture, exsanguination. Acute aortic regurgitation, 50% of the ascending dissection. Medial split undermines the support of the aortic valve and may lead to severe CHF. Branch vessel compromise, the extension of the dissection into the branch vessel, compression of the orifice by the intimal flap. Clinical scenarios including the stroke, paraplegia, hypertension, renal failure, visceral ischemia, and MI. Aneurysmal dilatation and subsequent rupture can also occur. Location of the tear, if ascending aorta, site of rupture is usually interpericardial, 70%, left pleural 6%, arch intrapericardial 35%, left pleura 32%, descending intrapericardial 12%, and left pleura 44%. The incidence is uncertain. Available information: 5,000 to 10,000 cases in a year in US, and the number may be higher. Not reportable condition. Few autopsies now. Autopsy series of 0.2% autopsy. Male 2 to 5 times more frequent than females. Ascending dissections 50 to 55 years old. Less than 40 years of MARFAN pregnancy, AV disease. Descending dissection 60 to 70% old. Most important factor leading to correct diagnosis is high clinical suspicion. Sudden onset of severe pain may or may not be catastrophic. Ripping, tearing, migratory, never experienced before. Restless sense of doom. Look for the underlying connective tissue disorder, hypertension, especially moderate to severe, or known aortic aneurysm. Severe pain 90%. Most severe at onset, anterior pain, paroxysmal dissection, posterior pain, distal dissection, and there could be a migratory pain. Pain in these locations usually due to or other more common disorders including pneumonia, pleurisy, pulmonary embolism, pneumothorax, ulcers, cholecystitis, pancreatitis. Ulcers must consider the aortic dissection in cases without other confirmed causes of pain. A. There could be a syncopial attack in 10%, omnious external rupture, hemopericardium. B. Stroke, carotid artery involvement. C. Paraparesis, paraplegia in the spinal artery involvement. And D is Horner syndrome. Physical examination shows acutely ill patient with hypertension, or it may be hypertension, aortic insufficiency in 50 to 60% of the ascending dissections, pulsus deficit 60% may change over time. B. Vary of the patient with acute leg ischemia and negative embolectomy, other sternoclavicular joint pulsation, high JVP, bruise, and abdominal mass. Natural history autopsy series. More than 50% of the people with untreated aortic dissections are dead within 48 hours. In 1934, Shinan, more than 300 cases reviewed, 40% of the acute ascending dissections died suddenly, none lived more than 5 years. Anagnostopoulos et al. Showed 973 patients with untreated proximal distal dissection, 50% died within 48 hours, 84% died within 1 month, 1% per hour risk of sudden death in first 48 hours. Acute 0 to 14 days, chronic 14 days plus. Diagnostic evaluation, chest radiograph, transthoracic echocardiogram, transesophageal echocardiogram, computer tomography, magnetic resonance imaging, and aortography. Chest X-ray shows signs of dissections are indirect, the abnormal aortic knob, widened mediastinum, pleural effusion. Insensitive and variable interobservable agreement. Look for the changes compared with old film. Displays intimal calcification. Useful in older patients. Normal 18%. A normal chest X-ray should not deter the further evaluation. Transesophageal echo procedure of first choice for dissection if readily available. Portability of equipment, facilities, emergency management by cardiologists, ER or ICU, high sensitivity and specificity, additional information, aortic regurgitation, pericardial effusion, ostia of coronary arteries and LV function. Computer tomography, rapid IV bolus and sequential imaging, 88 to 100% accuracy, limitations, no evaluation for aortic regurgitation, limited information on branch vessel, streak artifact may cause false positive, bone air interface may stimulate the flap, and false negative from the poor bolus of contrast, useful for follow-up in dissection. MRI, good alternative to TEE and CT if readily available, high sensitivity and specificity, can detect slow blood leaks, non-invasive, neither X-rays nor contrast needed, 90 to 100% accuracy. Limitation requires patient to be claustrophobic and apparatus without standard ECG monitoring, useful for follow-up of dissections. Aortography identify the intimal flap, true and false lumen, thickened wall, thrombosed false lumen, aortic insufficiency, branch vessel involvement, diagnostic accuracy 5 to 10%, false rate, thrombosed false lumen, simultaneous opacification of both lumens, misses intramural hematoma, this procedure, time delay in type A, coronary angiography usually not necessary in acute ascending dissections, surgeon can inspect coronaries. Treatment, ICU admission is in the tertiary center, immediate cardiothoracic and surgical consultation, close observation of BP, urine output and neurological status. Prompt blood pressure control is critical, can reduce propagation of dissection, decrease BP and LV contractility, decrease DP and DT, and sodium nitroprusside plus beta blocker, alpha and beta blocker, calcium channel blocker, heart rate slowing. Indications for surgery, consider operative treatment for all patients, hypotension, emergency surgery, ascending dissection, require emergency surgery, descending dissection, operation in the acute phase with no difference in survival compared to the medical therapy. High risk of surgery with renal failure and visceral ischemia, age more than 70 years. Risk of surgery is inversely related to the experience of dissection surgery. Goals of surgery: excise the intimal tear, obliterate the entry to the false lumen proximally and distally, and reconstitute the aorta with Dacron graft. If aortic regurgitation complicates the ascending dissection, the surgical decompression of the false lumen and resuspension of the AV leaflet should be done. The aortic valve replacement required if annular support of the leaflet damaged. Composite graft or homograft should be used. Aortic valve replacement required if aortic root is more than 5 cm likely to progress. Indications for surgical management include hemorrhage or rupture, end-organ ischemia, continued pain, rapid expansion of diameter, any segment of more than 6 cm, uncontrolled hypertension, younger patient at a relatively good operative risk. Follow-up: aneurysmal dilatation rupture are the leading cause of late death. One 1982 DeBakey showed 527 patients operated for aortic dissection, 30% of the late death due to rupture of the post-dissection aneurysm. In 1990, Crawford death shows death of rupture occurred in 12 out of 130, that is 9% of the patient, with a dilated but unrepairable residual aorta. After extensive aortic dissection, many patients will eventually require surgical therapy, especially if on the anticoagulant after composite graft repair. Before the hospital discharge, CT scan or MRI, the initial evaluation after discharge, CT scan or MRI at 3, 6 or 12 months, re-image aorta every 6 to 12 months thereafter, meticulous control of blood pressure dP by dt, starting with beta blocker or heart rate slowing calcium channel blocker. Avoid isometric exercises. Surgical therapy: the early operations attempted to create the re-entry passage of restoration of circulation to the ischemic branches. High failure rates. In 1935, Guerin fenestrated the dissecting membrane in iliac artery. In 1948, Paulin and James wrapped the chronic dissection of descending aorta with cellophane. In 1955, Michael DeBakey, modern treatment for aortic dissection. Colleagues Denton Cooley and O'Cree. First case of descending thoracic dissection, excision of the aneurysmal dilatation, oversewed distal entry into the false channel, end-to-end anastomosis of the aorta. Later, Dacron graft replacement of the ascending aorta. In 1962, Spencer Blake, first successful repair of the chronic descending dissection with resuspension of the aortic valve commissures. In 1960, the importance of sandwiching the friable aortic layers between the strips of Teflon felt. Bentel procedure, evolution of composite graft approach, aortic homograft and aortic conduit with AV sparing. Thank you.